So, as Dr. Tang and Dr. King mentioned this morning, why do we want the prosthetic treatment? Because we want to have a prosthetic outcome that is both functionally and aesthetically successful. We want to begin with our end in mind. We want to place your dental implant crown in a position that is both functional and follow the ideal emergence profile and give the patient occlusion. And not only that, when you deliver a prosthesis, you want to make sure your prosthesis can support the patient's oral hygiene and also not against the biomedical principle. And in the end, the most important thing is you want to have a prosthesis that is long-term and also the patient is happy with that. So before we begin, I think people like to see some failure case. So let's start some failure case here. So as you can appreciate here next side we have a fully edentulous arch. In this case, he wants to get the implant over denture. And as you can appreciate here we have 4 dental implants, and the orientation of the dental implants are pretty buccally inclined. So you can imagine that the screw hole will come out from the buccal side, and that will cause an aesthetic issue, and also the force from the mandibular teeth will be non-axial, so that is not something you want to see. And second, if you appreciate the photo here we have the lower lap 3 dental implants. And you can see the last 2 teeth are pretty mesially inclined. And although we did the custom involvement, you can appreciate that how close these 2 implants are. And even though if we make it as a cement retain restoration, we still might run into the issue, such as the cement retain with sulcus, that will eventually cause some biological complications. And this case here, you can appreciate that the screw is actually pretty close to the occlusal surface. So if you look at the X-ray here, the implant itself, the apical coronal height is actually pretty short. That's why patient keeps coming back and complaining about the screw loosening and some porcelain fracture. So how do we prevent that from happening? I think this is also a slide we have been emphasizing since this morning. First, we want to do a thorough medical condition, especially if you see your patient has uncontrolled diabetes, if they have a severe periodontitis, or if patient psychology is not an ideal candidate, then you don't want to treat these patients. And then after that, you want to do prosthetic treatment, so you have to combine the data that you have. Patient data can include the photos, CBCT, and the intraoral scan, so you can merge all the data together. And after you obtain these data, you want to go into the software and do the programming. From there, you can do the diagnostic work, wax up, and also design your surgical cut and fabrication if needed. And finally, you will go into the surgery and deliver the processes and do the methods. So here starts with one of my patients. This is my patient Karen, and as you can appreciate here, she fractured her tooth number 9, and she doesn't like the smell and she wants a dental implant. So how do we start? First, we ask what does the patient want, and also we evaluate the muscle. So you can see that here she has a very strong muscle. And also we want to evaluate patient's vertical dimension and see if patient goes vertical dimension. So I try to put this crown back, and this will give me the information about where was the apical margin is going to be. So ideally, we want to place our implant 3 millimeters below this. And not only that, we want to consider patient smile and aesthetics. So we want to analyze if the dental midline is on, and if not, how can you prevent that, and how can you cope? And let's look at intraorally. So as you can appreciate here, what do we see? So we see both, we don't have good posterior support. Patient doesn't really wear the partial denture. And also you can appreciate here, the open bite is actually pretty deep. And we have very limited interocclusal space. And ferrule here seems like borderline. We probably have around like 1.5 millimeter. And then we want to evaluate the space that you have 3-dimensionally if you want to place the implant. not just mesodistally, but also chronoapically, and see where's the zenith point is gonna be, because that will be your reference margin for your implant placement. And here, one good thing is patients' gingival body type doesn't seem too bad. And also you can notice that here we have a caries. So whenever we place the dental implants, not just look at the tools that patient wants to implant, but also try to focus on what the adjacent teeth have. And if you have a single tooth, it's not too difficult to estimate the mesodistal dimension and do the implant placement there. But what about if your patients have multiple teeth missing? For example, here we have anterior missing, and here we are also missing the molars. So how do you set up the teeth in a position that you can have a costal fossa for for posterior teeth, and anterior you also achieve the aesthetic outcome. So it is not easy. But the general idea before you start, you can estimate. For example, if you want to place an oversized implant, usually the mesodistal dimension is about 10 millimeter. And if you want to place the premolar size implant, the size will be around 7 millimeter. So you can do a rough estimate based on that. And also you want to consider the opposing arch because that will determine the interocclusal distance. And then at this, we should establish the first molar occlusion and help the patient with that. And if you are really unsure, what we can do is we can go back to the analog workflow. So after you take your diagnostic cast, you can have a better idea about the dimension, buccolingually, apicocoronally, about what the implant size you want to have. So in that sense, you can get the ideal costal fossa relation for the mandible and also for the maxilla, so you can achieve the ideal overgeminal bite. So that's how we do that in analog workflow. So if you have single tooth, that might be okay if the tooth space is too small. But if you have multiple tooth, you want to consider to do the diagnostic wax up. And here's another case that is about removable. So this is actually one of our residents' case. So as you can appreciate here, the mandible, we have a severe periodontitis. The maxilla patient is fully edentulous. So where do we start? So we started by doing the aesthetic analysis and facial analysis. And what is important here is we want to position our incisal edge in the ideal position. And that space should follow the requirement of ideal vertical dimension, respect the TMJ. So we design our denture in the software, and then we 3D print it and use the tooth-guided implant surgery to deliver the prosthesis. And this was a same-day delivery. So you can see how powerful the digital dentistry can be. And one important thing to consider if you have a single dental implant is how much space that we have. So according to the glossary of prosthodontic terms, the space analysis is a treatment planning for the prosthesis, 3 dimensions necessary for restorative material relative to the supporting anatomy. And this can be vertical and horizontal. For vertical, we need to define very carefully. The vertical dimension defined as a crest of the alveolar bone to the opposing occlusal plane. So I think this is really related to what material that you have. Because when you place a dental implant, you want to consider first the biological width. The second is the abutment height. And then above the abutment, you have the occlusal material, composite, and also the Teflon. And that all takes the space. And horizontal dimension, you will estimate what's the mesodistal and buccolingual width of your tooth. So for example, here you can appreciate this as a case that a patient has 100% deep bite and very canted like occlusal plane. And although we do have space, but would you place a dental implant here or not? You can think about if we place a dental implant here, the top molar is really super erupted, so we don't have a good space to do any protrusive or lateral movement. And also, patient wants to get a dental implant here, but you can see the space is quite limited. So if we place a dental implant here, the material might fracture, and that's the thing we don't want to foresee. So in PROS, we have a terminology that is called the crown height space, and that is defined as the distance between the occlusal plane and your bone crest. Ideally, you want to get 8 to 12 millimeter according to the literature. But imagine dental implant is not easy to get that space because when you lose your tooth, you might have the opposing tooth super erupted or you don't have enough space. And ideally, the screw retained crown will require less space, and semi-retained crown will require more space. And I wouldn't give a number here, but in generally, it's about 5 to 7 meters, as Dr. Shimizu will discuss about this. And another thing to think about is about the crown to root ratio. And in our natural teeth, the ideal crown to root ratio is about 1 to 2, and maximum we can accept is 1 to 1. But in implant dentistry, we have to think it differently, because in dental implants, we have the osseointegration. So multiple studies they have done with animals and also clinical study, they have found that even if you have a very high crown to root ratio, you will still have the good survival without any major complications. And here's another thing like I like to discuss with my periodontist colleagues. And when they place the implants, they often decide like how deep the implant is gonna be. So there's a term, it's called the emergence profile angle. And this angle is determined by your root axis and your crown axis. And ideally, this axis should be between 15 to 25 degrees. And if you have more than 45 degrees, what will happen is you will expect the crest of bone loss. And this is not only in animal study, but they have found this also happen in human study. So what do? We want to have a gradual emergence profile that respects the biological. And this is another important slide that we talk about. And this was actually published at University of Pennsylvania. And we talk about critical and subcritical contour. So after you place the dental implants, especially in the anterior teeth, you can do a provisional crown that will help to form the periimplant soft tissue. So where is the critical contour? The critical contour is at the highest spot of your apical margin, your crown apical margin, and that will determine where is your future CJ is going to be for your implant crown. And also we have the subcritical contour that is immediately below the critical contour to the implant envelope. And that will help us to form the periimplant soft tissue. Either you can be flat, convex, or concave, depending what you like your tissue to be. So the ideal subcritical contour would be flat because you want to keep your soft tissue. You don't want to compress too much your soft tissue. And this is a case that I did with my co-resident. So you can appreciate here the critical contour will rest at the CJ. And the subcritical contour will be slightly concave. So that will give the room to the implant prosthesis to have the ideal interproximal or facial periimplant soft tissue. Okay, and here is one of my very first dental implant case. So tooth number 7 and tooth number 10, they are both dental implants. And you can see here, this is a final crown. And I would say that the soft tissue, if you compare 7 to 10 seems a little bit less ideal. So I would say like if during the healing stage we can try to push the tissue a little bit, maybe the outcome will be different. So that's something we have to think about, especially in your case, the mesial distal papilla, how much you want to get. And the next thing is sometimes you'll run into the this kind of case, if you have very limited interocclusal space, what would you do? So here you can appreciate that lower anterior teeth are kind of supraerupted, and posterior teeth, the occlusal plane seems like very different with the anterior plane. So what can we do? We want to start with the conservative method. So what can you do first is you can consider to reduce or even extract the supraerupted teeth if necessary. And this means that you can do some enameloplasty. And second thing is, as Dr. Tang mentioned earlier, we can consider to do a surgical reconstruction of the edentulous space. And then, of course, you can consult your orthodontist to help you to intrude the teeth, and that will give the space. And lastly, we can consider to increase the occlusal vertical dimension. And what about removable case? You will run into cases that patient is completely edentulous. So where do you want to place your dental implants? It's not easy to estimate. If it's a single crown, you can easily picture where you want to place your dental implants. But if it's fully edentulous, you want to start with where your teeth will begin. So first thing I usually do is I estimate the occlusal vertical dimension and make a conventional denture first. And after that, what you can do, there are multiple ways to evaluate how much restorative space is available for dental implant. And the literature show here, first thing you can do is after you do your diagnostic wax up, you can try in the patient's mouth. And if you like the space, you can melt your wax and use your parallel probe to measure how much space that you have. And from there, you can either trim down your bone or augment your bone. And there's another way to do this. You can also deliver your denture first. Then you can duplicate your dentures or 3D printing a denture and put this visual marker on the top of it and merge with your CBCT. Then put in the software to see how much restorative space that you have. So here I just wanted to show the dual scan protocol. And here, as you can appreciate, upper we are missing all the teeth. And here we deliver the dentures to patients first. And then we merge it with the CBCT. So here you can kind of see the fringe and also the teeth position. And in that sense, it can help you to estimate where do you want to place the dental implant. And not just that, if you have a single tooth, that should be fine. But if you have multiple tooths and you want to change the vertical dimension, CBCT is also a very, very powerful method. For example, here you can appreciate that the patient has deep bite and he needs a full mouth rehabilitation. So what I did first was I did the diagnostic wax up at an increased vertical dimension. And after that, I duplicate this wax up and started my tooth preparation. And then I deliver the provisional at the increased vertical dimension. And then what we can do next is, I feel this is really incredible. Like we can put the visual markers on the provisional too, and then you can scan this together, and you will merge into your CBCT, so you get the ideal implant position, and you know how much space that you have occlusal. And another thing we have to think about is if you have fully edentulous patients and the patient wants to have implant over denture or like implant fixed prosthesis, how many implants are we going to give them? And what are some considerations and where are we going to place them? So for example, you have to think about, are you restoring the upper or lower arch? If you are restoring the upper arch, the minimum implant number that we can accept is 4 dental implants. And the mandible, according to McGill consensus, we should at least get 2 dental implants. And not just that, we have to consider about the arch shape. If you have the V-shaped arches in your mandible, you want to place your dental implants as anterior as possible. And if you have your U-shaped arches, you want to place at the canine region. And the reason behind that was because you want to reduce the cantilever force that will apply on your posterior ridges. And then if your patient wants to do something fixed, how do you prevent that? So for fixed restoration, I think many of you might have heard of the 014 or 016. So at this, we need 4 dental implants. But now to be on the safer side, we want to get as many implants as possible. So usually we do 6 implants. And where do we place them? We usually place on first molar, canine, and then the lateral incisor if possible, because you want to spread your implants as much as you can. And also sometimes you'll get a request from patients. They want to do conventional crown and bridge type implants. So it should look exactly like as if we still have the natural teeth. In that sense, you have to place at least 7 to 8 dental implants in order to achieve that. And this is from Dr. Mish. So Dr. Mish actually published this in a magazine. So he talks about when we do a full arch implant prosthesis, how do we classify our restoration? So first thing, if you have an edentulous patient, you want to know how much tissue and bone support that you want to have, the lip support, and how much vertically and horizontally you have lost your tooth. So according to his classification, FP1 means that you are trying to restore as conventional crown and bridge type dental implants. And FP2 type, you will have a little bit of the dental root. And the third type is the FP3, because the bridge resorption is so severe. So you are not only replacing the crown, but also you want to replace the soft tissue. So that's why you will need a pin porcelain. Okay, and let's go into cases. And I see many dental students here. And this is actually my very first dental implant case in 2020. So I want to share this case with you. So Belinda was referred to me from orthodontist, and she is congenital missing tooth number 7 and 10. So as you can see here, we have a little bit loss of the tissue vertically. And also you can appreciate that her crown, her tooth is pretty square and has a lot of texture. And this is a root angulation that is not too bad. Before I do any dental surgery, I still like to take some periapical films because that gives me the idea about how much bone I will have. Sometimes the CBCT doesn't show that well. And then I like to do like through data collection. So I like to take the intraoral photos and evaluate the ridge, especially from buccal and occlusal view. And another important thing is about protrusion, because anterior teeth, the teeth are inclined to incline. So you don't want to apply too much of excess loading on your teeth. So you want to check the guidance and to see where will be your future incisal edge going to be. And the next thing I did was an interim partial denture, because this patient is very young, so we want something she can smile with. So first we deliver an interim partial denture, and I try to evaluate the future gingival margin that I wanted to be. And also the good part about this is you can utilize this and do the dual scan. So that's what we did. And as you can appreciate here that I did the dual scan, and also you can appreciate how thin the bone is gonna be. So in this case, we decided to go with 2.9 by 10 millimeter. And because the space is very limited, and you want to make sure you have an ideal implant position, so we decided to do this guided. So this is how it started. And then I just did a very simple mid-crestal incision and open the flap, and then place the implant surgical guide on the implant side, and then did the guided surgery. And do the simple interrupt sutures. And after that, because you can imagine this is a 2.9, and the primary stability probably will not be too good. So what we can do is we can submerge the implant, put the cover screw on, and let the tissue heal. And in this case, we let the tissue heal for 6 months because we want the aesthetic outcome. And then, I graduated, so I transferred this case down to my co-resident. That is how it happened at school. And then this was a photo that my co-resident sent it to me. So here what we see is we have a custom gold-plated abutment here, and the angulation is still buccal. And here you can see that we place our margin right slightly below the future general margin. So between selection for custom healing abutment and angulated abutment, how do I select? For anterior case, I would like to know how deep the margin is going to be. If that's the case, I prefer custom healing abutment whenever it's possible. And in this case, you can appreciate we are going to have a cement retain restoration. And then for abutment, we do have many different choices. And this is from textbook of Dr. Panos. And you can appreciate that we can choose the gold, titanium, zirconia if you have an aesthetic case, you really want very good aesthetics, or you can also use the PICC abutment. And nowadays I prefer to have the type base with the either the zirconia or EMAX if possible. And this is how it looks. And I wouldn't say this is perfect because you can still kind of see the tissue defect here, but the patient is really happy with that. And this was the final result. And another thing to be careful is patient's oral hygiene, because you want to make sure patient can keep really good oral hygiene. That would be the long-term success for the patient. Okay, and then the second case I would like to share is a 4-month rehab case. So this patient, he is from Dominican Republic, and he mentioned that he broke his teeth a few days ago, and as you can appreciate here, he's wearing the partial denture. He only wears the top but not the bottom. And this is a metal-based partial denture here. And he wants to get the dental implants if possible. So here we can appreciate a few challenges. First is the occlusal plane, which is the ideal occlusal plane. Anterior teeth, we have super eruption. Posterior teeth, we have a closed spine and also very infra-occlusion. And second thing is how much interocclusal space would you do here? If you just place the implant here, you can imagine that the implant position will be super buccal, so you might have a big cantilever that you want to avoid. Posterior seems fine, but you don't want to have a big step between anterior teeth and posterior teeth. And this is how patient present with a partial denture. So patient doesn't raise the vertical dimension. We still keep the tooth contact in the posterior. And another thing patient doesn't like is the canine position. He feels whenever he smiles, the canine looks really high. So how do I start? I spend a lot of time doing the prosthetic implant planning in this case. So first I evaluate the patient's vertical dimension. And this is when patient closes down at the maximum intercuspal position. And we don't just want to see patient from the frontal view, but also we want to evaluate patient from the lateral profile view. If you see a cross-street facial profile, that is very likely patient has loss of the vertical dimension. And this is a repose position. So how do we get the repose position? Is you can ask your patients to speak, for example, like Emma, so they can open up the lips a little bit to get that rest position. And you also want to evaluate patient's smile and to see where would be the future crown and implant junction is gonna be. And I always like to take the diagnostic cast and photos if possible, because when patient is in the chair, we can see everything, but if patient laugh, we don't have anything. And although human body is considered as the best articulator, but you still want to simulate the movement of your articulator. So here we can appreciate that patient has a scissor bite, close bite, and there are also some spacing issue, and also we miss a lot of teeth, and the Friedman attachment here is considered high. And second thing, in addition to CBCT, you want to take the panoramic film and periapical film, because that will give you the general idea about where is your bone level. And before we place any dental implants, we have to build the foundation well. That means ideally we should treat the periodontal disease properly before we do any prosthetic work. So the first thing I did was I referred the case to my periodontist. And as you can appreciate here, we have some deep probing and some breathing on probing, and some teeth are considered irrestorable. And although the mandible doesn't look that bad, but imagine if we want to restore the occlusion to an ideal occlusal print, it might be really challenging. So treatment planning is actually a decision that between prosthetic and also periodontal. And the second thing I did here was I evaluated the vertical dimension. So there are several ways you can evaluate a patient's vertical dimension. You can just look at the facial height. So the lower facial height is defined as the distance between your nose and between your chin. So ideally, your face should be 1/3. And also you can test the phonetics or have your patient swallow and evaluate the vertical dimension. And the way I like to do, I feel this is more like objective, is you can make a landmark, one on the chin and one on the nose, and mark it with the marker so you know this is a distance when patient bite down. And then you can ask the patients to speak a word that will help them to relax and mark the second line. And this distance, according to the literature, if you have a class 1 dental occlusion, that should be 2 to 4 millimeters. And if you have class 2, the distance will get larger, and that will be 4 to 6 millimeters. And if you have a class 3, that will be around 1 to 2 millimeters. And then right now, I like to play around like analog and digital workflow, because I feel in this case, if I do the diagnostic wax up, I still don't have a big picture about where my occlusal print is gonna be. So the first thing I did was, after I got the diagnostic cast, I scanned it and put into the virtual articulator. And from here, we can estimate where would be the ideal occlusal print. And then you can increase the height of your incisal pin, and that will open up the space for your restoration. So from there, I have a better idea about where to put my occlusal print and dental imprint. And then before I jump into dental surgery, I still went back with the treatment planning carefully to discuss with the patient. So I got the diagnostic cast. And second thing I did was I would like to evaluate patients' overjet and overbite and get the ideal vertical dimension that I want to restore. So I made the wax ring. And this is pre-made in the lab. And then I set up the teeth chair side to get the ideal occlusion for aesthetics. And then another thing I did was, because I increased the vertical dimension. So if you want to increase the vertical dimension, literature they have shows that the maximum you can increase is around 5 to 6 millimeter. So if we want to increase more than that, we want to have a device that can help you. And here I did a kind of basic arch tracing to find this central relation position. And from there I took the bi-registration. So from there I can mount my cast at the ideal vertical dimension. And then I went back and had a discussion with the patients about which treatment option should we do. We can either do the removal option, just like where the patient had, and maybe do some onlays and crowns to level the occlusal plane. Or we can do the bone reduction. Because in this patient, he does have a lot of bone. It's not like we have to do the bone graft. So in this case, we actually decided we can reduce the bone and do the complete arch fixed implant prosthesis. And that would be the 0-on-6. But with either option, because previously I got my ideal vertical dimension with the bi-registration. So I'm not worried to go with the either option. And now if you want to do full mouth rehab, what we can do is we can do the stackable to supported surgical guide. And this will involve collecting the patient data. Patient data will be like patient scan, bi-registration, and diagnostic exam. And in this case, although we decided to go with the complete arch fixed implant prosthesis, we still want to keep the vertical dimension during the treatment because implant is still healing, so we don't want to have too much force on it. So how we decided that was we decided to keep the third molar in place. We are not extracting at the day of surgery. And then here we have the anchoring pin, and we designed the two supported implant surgical guide. And second thing is you want to have a bone reduction guide. And again, this bone reduction guide is resting on your tooth. So that will give you an idea about how much you want to reduce your bone, and this can be really accurate. And then from there, you can plan your implant position. So nowadays, if patient can do 0-on-6, I would prefer to do that. Because for 0-on-4, let's say if you lost one implant, then it's very hard to restore because there will be a lot of forces on the prosthesis. But if you have 0-on-6 and you lost one implant, that is not too bad. And then we went on to design the implant surgical guide. So here we have in total 6 dental implants, and ideally it should be on the palatal side. So one thing I've been thinking about, would you say hybrid process is surgical driven or implant or prosthetic driven? I think that's the thing we have to think about. And this would be the implant position. So as you can see, this can be stackable surgical guide that will rest on the guide that previously we set. And then because we want to do immediate extraction and immediate loading, so we also designed a provisional restoration. And that was a long day. I worked with the pararesidents, and we went through like surgical team together with the implant company, and we decided to do a surgery from 7 o'clock in the morning until 7 o'clock in the night. So that's a long surgery day for the patient. So first thing, before you do anything, you want to make sure patient's periodontal condition is really stable. So before we jump into the surgery, we actually had gone through the phase 1 therapy for 3 months before we do anything. And then we try on our implant supporting guide, and it fit quite well. And then we went to raise the frag. And here, as you can appreciate, because you want your guide to be really stable, so not just use your finger to be on one side, you want to use the anchoring pin that will help you to fixate really well. And then the next thing we did was we extract the teeth carefully. So for molar, if we want to place dental implants, a lot of cases we will see a lot of either periodontal disease or retained root. So we want to carefully section the tooth if possible, because you don't want to lose more of your buccal bone. And again, as I said previously, we preserve the third molar because that could serve as a guide for the surgical guide, and also we can keep the vertical dimension during the healing. And then here we utilize the piezo surgery that will help to cut the bone more precisely and also more evenly. And after that, we grind down any rough edges that will interfere with the implant healing, with the bone ruptures. And then you see here, so the implant surgical guide will raise on the top of the surgical guide, so they will snap on, so the position will be really stable. And from there, we started to place the dental implants diagonally, because you want the implant guide to be still stable after you place a dental implant. Sometimes if you place the dental implants one by one, you will notice that when you go to the other side, it's not that precise. So here we did like diagonally place the dental implants. And after we place the dental implant and confirm that we have a good primary stability, then we went on to choose the abutment that we want to use. And this is also determined before the surgery. And after we select the abutment, we put the temporary cylinder onto the top of the implant. And then again, here is a provisional restoration that rests on the top of the surgical guide, so it also snaps on. And the benefit of using a surgical guide is we can have ideal occlusion. Sometimes it might be a little bit missed, but usually it's not too bad. And then because we want these processes to go into patient's mouth, so we did a pickup. We connect the temporary abutment to the provisional processes using the compact resin, just to stick them together first, and then we unscrew the temporary cylinder and use the pattern resin to fill the back and connect to the implant processes. And this 3D printing provisional was inserted to the patient's mouth again. And because there will be multiple screw holes from the temporary cylinder, so we try to fill that with PBS, and that can be really filled. And then this was the provisional processes delivery. And then we confirm with patient smile, because this is a big surgery, so after the surgery, what we should do is we should take a panoramic film and also the post-surgical CBCT if there's something you feel that might go wrong. And then also, I graduated again, so this was the transfer case. This was the final photo that I got from my co-resident. So here, before you take any final impression, you want to make sure your tissues are very healthy. And you don't want to see any bleeding. It's normal to see a little bit pink, but it shouldn't have any oozing. And then for the materials, we decided to go with monolithic zirconia because we want the strength and also aesthetics. And these are the stem from the monolithic zirconia. So here you can appreciate that we increase the vertical dimension and get the processes aesthetically and functionally, and not just that, posteriorly we place the dental implants. It doesn't show here, but we did place the dental implants because in order for processes to become successful, you want to have good posterior support. Your posterior support should support your anterior teeth, not just for aesthetics. That's for the long-term processes. And conclusion, I think it goes back to how we started. So before we do any implant surgery, we don't want to just jump in and place the dental implants. We want to have a careful planning that is multidisciplinary. So first, case selection. You want to go through all the medical history, and just like how we build a house, we want to build the foundation first and treat the active disease before you do anything. And for data collection, right now we have so much digital tool, not just CBCT or intraoral scan. Right now in our school, we have been trying to integrate with the facial scan and also the digital smile design as well. And after that, after you got your diagnostic test, you can either go with the analog workflow, do the diagnostic wax out with the traditional wax, or you can do it virtually, doing the virtual wax out as well. And from there, if possible, try to do guided surgery as much as you can, because that can make sure the position is ideal three-dimensionally. And eventually, you will go into the surgery. So surgery should be the last step, and then that can make sure you have the success prosthetically. And not only that, after the treatment, you want to make sure your patients come back, maintain the oral hygiene, also the prosthesis. So last year we have our Dr. Nepa, David Nepa, and he wants to say hi for everyone. So he reminded me this, like we really need the team efforts. It's from restorative team, surgical team, laboratory team, and orthodontic team. Yeah. Okay, and lastly, I would like to thank operations